Hi there, I'm Lisa Morad-McCoy. I am a therapist and senior program therapist at Community Behavioral Health, which is a division of the Department of Psychiatry. And I'm just really happy to be with you today to talk about clinical telesupervision.
Hello, my name is Molly Faulkner, and I am also at the Division of Community Behavioral Health, and I am so glad you're here today. It's wonderful to see so many people across the state involved in this symposium, and I see some very friendly faces and some new ones, but thank you so much for joining us today. I'm going to do my best to get our PowerPoint up here so we all can see it. It'll take me just a moment. Let's see if this one. There we go. Can everybody see the screen? Are you able? Okay, great, great. Well, Lisa and I today are going to be talking with you about clinical telesupervision. We're sorry to say that our colleague Jennifer Yanez was not able to join us today. Just she had some other commitments and she will not be presenting with us, but we do work intimately with Jen, and she has so much to add to any conversation regarding this topic. This is information on how to receive your continuing education, CEs, and certificate of completion. Jen will go over these with you at the very end of today to assure that you get your CEs. We don't have any financial arrangements related to the content of this activity. Sorry, just trying to move my screen around so I can see this. So today's agenda, we're going to be talking about a variety of topics. And really, we're going to talk broadly about the foundations of clinical telesupervision and how important it is that you know those. Supervision and telesupervision policy in New Mexico will be reviewed. It's really important that you know that what the supervision and telesupervision policy is within the state that you practice. That's probably one of the most critical aspects of the of practicing. Also, we're going to talk about advantages and challenges of telesupervision. There are both advantages and challenges, and also cultural considerations of telesupervision. We're going to speak to the components of a quality telesupervision practice. We will also talk about our program here at the Division of Community Behavioral Health at the University of New Mexico, which is Access to Clinical Telesupervision, ACTION New Mexico. We'll also have some breakout rooms today. We're going to be encouraging conversation amongst the group, the attendees, and we'll also have opportunity for questions. Now we're going to take a poll, and I'll turn this over to Lisa.
Okay, so we're going to take a poll just to check in and see who's in the room and what your familiarity with telesupervision is. And so I'm going to initiate the poll and just go through and answer the questions for those of you who aren't familiar with how to take a poll on Zoom. And then you'll see a button that allows you to submit the poll. And then we'll all get to see, and it's all anonymous, we'll all get to see the experience that is in the room. And Jen, I don't see the poll in my, oh, there it is. Got it.
And if anybody can't see it, it may have popped up behind your video screen, so you may have to minimize the video in order to see. We'll run it for about 15 more seconds, and then we'll all look at the results together.
Okay, thanks, Jen. So it looks like a lot of you are somewhat familiar with telesupervision, and a lot of you, like all of us, right, in this COVID-19 world, started providing telesupervision about 6 months ago, which makes a lot of sense. I think the numbers would be really different if we did this in 2019. So it's great to see all of this experience. And for those of you who don't have experience with clinical telesupervision, that I'm so glad you're here. And hopefully it'll, just inform your practice. And for those supervisees who are out there, it may open some doors in terms of what you need for supervision.
Yes. I also noticed that 47% of you have started providing telesupervision within the last 6 months, which is no surprise because of COVID for sure. And I was thinking about this. I certainly did not have telesupervision. I got my license many years ago before we even had the means to do so. But I would imagine as time goes by, we would see more people having been supervised using telesupervision now that it's been more, now that it's opening up. Thank you so much. We're going to begin with speaking about the foundations of clinical supervision. What is telesupervision? Well, we know that telesupervision is through an asynchronous audio and video format where the supervisor is not in the same physical facility as the trainee. Just to let you know a bit about myself, it just occurred to me that I actually been doing telesupervision for approximately 6 years. So it's been a while. And I've seen many advantages in telesupervision as time has gone by. A face-to-face meeting, it can also be a face-to-face meeting using HIPAA-compliant meeting software like Zoom. It's so important to have that HIPAA compliance so that you can protect the confidentiality of the client and the content with which you're speaking. But really, telesupervision is where meetings can take place anywhere there's connectivity. A PC or mobile device, and also really privacy for clinician and supervisee. This is really critical. I know in my work, I often have to ask to be sure that people are in a private area so they're able to discuss client issues when you're talking about telesupervision. And in many states, including New Mexico, clinical supervision can be done over the telephone with no video. And certainly we'll talk a little bit more about what the rules and regulations are here in New Mexico. It's important to just tell you that only a third of social work boards in the United States allowed some telesupervision prior to COVID. And we know that things are rapidly changing, obviously due to COVID and people working from home. And we're going to talk a little bit today about the emergency orders that have helped make these changes happen, at least temporarily. Why telesupervision? Well, it really makes sense. You know, when people can't get clinical supervision, there are limited chances for promotion. Therefore, when you provide them telesupervision, there's a clinical approach, then you're able to have your LCSW or your advanced practice independent licensure and be able to be promoted. There's also little opportunity to start a private practice without an independent license. We know this since it's so important. Fewer chances for professional growth, and it actually may result in a provider moving to an urban community to get that clinical supervision. Therefore, they would be taken out of the rural areas where we so desperately need providers. So that's another reason why we might have telesupervision. And just really underscoring the issue of clinical supervision, period. We have such a desire and need for that. When I was, not to mention just telesupervision, but when I was in my early days of my own practicum and practice before I got my LCSW in the 90s, I was grateful for that clinical supervision. I think it really helped make my practice better, and it better quality of care to my clients. Now I'm going to talk to you a little bit about telesupervision policy overview. In the United States, we know prior to COVID that telesupervision had been limited, quite limited, actually, and that emergency orders have led to those changes, at least for now. I wanted to, and again, we talked earlier that only 1/3 of the social work boards allowed telesupervision prior to COVID, and counseling boards allowed telesupervision in only 6 states, and they were discussing in 18 states and prohibited in 19 states. And this is from an article by McAdams and Wyatt back in 2010. What's important that another thing that was important I wanted to add to this is that there is this is a URL to a website. It's called We Are Motive, is the site's name, and it is really trying to encourage telesupervision and connection. It is also a private site, so they're wanting to pay a price to kind of hook you up with the supervisor. But what I liked about this and what I'm trying to send you to in this URL is the fact that this talks about all the telesupervision rules across the country according to your profession. So whether you're social work counselor, psychologist, you can go to that website and you can find out in which state they have it all listed out for you, and they have all the rules. I was trying to find a handy dandy map like this. We have this wonderful map about where social work telesupervision is allowed. And quite frankly, the team here at Community Behavioral Health been working on this for some time just to try to understand where telesupervision was allowed for social work across the country. And this information came to us from a private communication with an educator in Texas who was looking at some of these issues. But as you can see, you have different states that allow different levels of telesupervision. The green states, they allow telesupervision without restriction. The yellow states are allowed with caveats, and the purple states are allowed for a limited amount of hours. And again, here in New Mexico, we're quite fortunate because we allow unlimited telesupervision and have for many years. In New Mexico, telesupervision or telephonic supervision may account for no more than 50% of the postdoctoral supervision hours. The supervisor must have formal policy addressing that utilization of telesupervision or telephonic supervision as specified in paragraph 5 of subsection B of 16.22.6.8 New Mexico statute. I really encourage you, and we're going to give you the websites for each of these, encourage you to always keep up to date with what the rules are within your profession, because as we have found, they change. And it's so important that you, if you're providing the service in any place, that you are there to, that you are up to date with those rules, board rules. In counseling here in New Mexico, normally telesupervision was not allowed by the New Mexico Counseling Board, but this just talks to you about the change in place, the change that's occurring. The current emergency order allows for telesupervision and telehealth, okay? And the Counseling Board is interested in changing those rules to always allow for some percentage of telesupervision. And that's really good news. It's good news for people who need clinical supervision and have a hard time accessing it. And it's good just because it'll be in our board, counseling board rules. And this on the right side is that example of that rule. And I'm just sharing with you, if you go to the websites for these counseling and therapy practice board, they will have this emergency order for you to download yourself. And I keep these types of things in a folder for myself so that when I am needing to speak about it or I'm needing to talk about it with a supervisee, that I have that readily available. And here is a chart, really. The chart just says, it's a summary of what I was sharing with you about New Mexico's number of hours for social work, counseling, and psychology. We see here that counseling has 100 hours, and you can get all of your hours currently through the emergency order for telesupervision. In social work, we have 90 hours total for supervision. 20 hours can be group, and 30 hours actually can be interdisciplinary. Some people don't even know that to this day in New Mexico, but it's been that way for a number of years. They can get their supervision through counselors, psychologists, I think and social work. And then telesupervision, we get all of our hours of social work telesupervision. And for psychology, as we were looking at earlier, they have 3,000 hours, and they allow you to have approximately 50% of those hours currently. And here are the telesupervision policy and board resources. I really, again, encourage you to keep this slide once Jen has it uploaded to the chat, to keep this slide available for yourself so that you can connect quickly to these rules whenever you need. I wanted to, I have no reason to promote this book other than I really like it. And it's something that came out in the last year or so that I was able to purchase. And this is the book, and it's called Using Technology to Enhance Clinical Supervision. This is a really good summary and detail of many aspects of clinical supervision that we're not going to be able to go into today, but I'm here to tell you it's excellent. They've got everything from technology and elements of practice, applications of modern technology and supervision, how you can do it through email, how you can do it through telephone, what are some of the caveats and expert practices. So anyway, this is a book that I chose to put up here today. It's a new resource for me, and I'm trying to get through it. Okay, so now we're going to go into starting telesupervision. These are a few things that you're going to need. You're going to need a signed supervisory contract. For those that are due supervision, it would be interesting just to post in the chat whether or not you have a signed supervisory contract. I'd be interested in knowing that. And it's important to have, the nice thing about the supervisory contract is it really helps the supervisee know what you're agreeing to provide them, but it also allows them to tell, or gives you the limits on their behavior. So you need to know what that you're expecting of them. Anything from you expect them to be on time, you expect the level of professionalism, you expect them to come ready to supervision. There's many, many aspects you can put into your contracts. We have some examples in down the road, and I'll tell you about those. But you can also find many examples on the web. Some are better than others. But I just think it's critically important to make sure that contract tells it exactly the way you'd like to see it and the way your supervisee would like. One of the things that we do in our program, New Mexico ACTS, is we make sure that the supervisee knows that the last word on whatever case they're bringing to us, that they are talking to their supervisor there and their agency that they're working in, but we want them to know that, legally they have to follow the guidance of the supervisor there at their agency. So we have that in the contract. It's really specified. We rarely ever have any disagreement with what people would want to do at an agency versus what we would recommend. We also have their agency supervisor also signs a contract and understands that they're getting supervision from us. So that's just something special we do because we're doing it with an agency. You need to have a HIPAA-compliant televideo platform such as Zoom, Verily, or Simple Practice. I have never used Verily for Simple Practice. I've always used Zoom, and it's been a very easy way for me to provide supervision. You also need to assure that there's a private room for that supervisor and supervisee, and you might even have a noise machine outside your office when you're providing that supervision, and you might encourage your supervisee to do the same if they don't have that privacy within the space they're doing supervision. What's really important is to have consistent bandwidth and access. It's important, we know this is critically important for those of us who've been on a number of meetings, Zoom meetings, is if you don't have that consistent bandwidth and access, it really makes for a very choppy, if not unusable session, right? So that's really important. And that's also a limitation for people out way in rural New Mexico. We also need to have consistent phone access. I don't know how many times I've had it where I have actually had to call on the phone because my Zoom wouldn't work because of the problem with bandwidth. You need a computer, you need a camera, telephone, and microphone. And very often, most of these are all, your telephone is separate, but all of this can be included within your computer or laptop these days. So that's nice because you can usually get that. Certainly you have to have internet access. And you either need to have a notebook or electronic file for documentation of dates, topics, and hours of supervision. We keep this on an electronic Excel file. It seems to work best for us to figure out those hours. And I also recommend that my supervisees keep their own records, because this is very helpful while you're working with somebody, as well as at the end of your supervision, to assure that your hours are matching up when you're turning those in at the end of their time, end of your supervision. For decent connectivity, Jen was able to find, I was really impressed, that Indian Health Services recommends 1 megabyte per second on a PC and 4 gig with at least 2 bars on a phone. Quite frankly, I've done Zoom in Indian country, and I've done Zoom in Mexico, and I've never realized that. But this is really the connectivity that you need to be able to do online Zoom. Documentation really helps to guide your supervision. It helps you remember, if you're seeing one person for supervision, it's probably easier to track. If you're seeing several, it becomes very complicated. So you need to be sure that you keep documentation to help guide your supervision. We use a group of, and I'll talk to you about that in a minute. We use some areas that we are sure to cover, that we want to have covered in our supervision, but it's just important that you can say, oh, well, we've talked about assessment and evaluation. Maybe it's important that we talk about diagnoses and the DSM-5, or do we need to talk about other aspects, right? Both parties, as I said before, should keep records. I've said that more than once because I've had my fair share of need for that. So it's been great when both parties do. But I will tell you that most of my supervisees have to be reminded of that. It's not once they know that you're keeping track, they don't always keep track. But some do. Some are quite compulsive when you do that. Again, it provides essential feedback and evaluation on the supervisee's progress. It's quite different from the notes are quite different from somebody who begins supervision with you, has never had any kind of clinical experience, and then in the end, when they're finally finishing up, it kind of demonstrates within their documentation, your documentation, how far they've come. It clearly maintains a record of hours, which is so important. We need to make sure those hours are there and agreed upon. We use the NASW 10 core competencies of supervision. That's what I was saying earlier, that we want to make sure we have the documentation that helps to guide that supervision, but we want to make sure that the core competencies are actually being introduced. I do not have any core competencies here for counseling, nor do I have them for psychology. I would really like that if somebody has those or has something that they utilize within their practice. Because I would just love to have that information for my own files. And again, like I said, you may have something specific for psychology or counseling that I'm in. So we're going to talk briefly about the, hold on just a second, I'm going to double check the chat, see if there's anything there.
Molly, I was just saying that it's actually funny that you mentioned the core competencies, because that is a major part of the interdisciplinary supervision workshop next week. So folks who are wanting more on that should come to that. Great,
thank you so much. Oh, it's so nice to see Jason Maloney on here. All right, I just was in a meeting with Jason earlier today. Super. And Jen, feel free to jump in if you see something in the chat. I want to be sure to keep us moving along, so I'm not looking at it as closely. So these are the NASW's example of 10 core competencies. To identify, you identify as a social worker and you conduct yourself accordingly. Obviously, you would, if you were using this for psychology or counseling, you would just substitute the word counseling or psychology. But I bet you have your own core competencies. I'm almost certain of it. Ethics, to apply social work ethical principles to guide your professional practice. We know this is so critically important, and it's important to be sure that we're talking about this in supervision. I think critical thinking is right up there with number one for me, because you need to apply critical thinking to inform and communicate with professional judgment. We talk about this a lot, that it's that ability to be able to hold many things in your mind at the same time and then determine which is the most critical to start with the client. By the time somebody's finished with supervision with me, and hopefully within as they're rounding out their last 30 hours, I'm looking for a level of expertise in their ability to think critically. You want to be sure that they are able to understand diversity and how they engage diversity and difference in their own practice. It's very different from one group to another, and it's important that they understand it. Rights. One of the main things in social work is human rights, and we are definitely advocates, and that we need to advance human rights and social and economic justice. And how might you encourage that within your supervisee and in the work that they're doing with their clients? I'm trying to think of an example of working with people that are extraordinarily poor and trying to help them understand how to help them access social and economic justice for themselves. That is something that can be done within clinical work. Research, how to engage in research-informed practice and practice-informed research. This is so critically important to the work that we do. And we all know that sometimes research doesn't make it into the field for a number of years, but we need to have ongoing examination of and implementation of current research with human beings. Knowledge, how do they apply that knowledge of human behavior in their social environment? How do they apply the knowledge of I work with children and adolescents as well as adults that have developmental disabilities. So how do you apply your knowledge of human behavior and where they are in their age, what's age appropriate and what's not, and in their social environment? How does that social environment affect them? We also want to make sure that they are understanding how policy impacts their clients and how it impacts the care they're giving, to engage in policy practice to advance social and economic well-being, and to deliver effective social work services. We also have down as number 9 to respond. We need to respond to the context that shape practice. We have had a great deal of the context of the country has been in relationship to racial injustice and social injustice this summer in particular. And social workers are always have this in their minds because it's just part of how we are educated. But you need to be able to respond to the context in your environment that might shape your practice. And then, of course, just your basic, how do you engage with clients? How do you assess them, intervene, and how do you evaluate? And you need to be looking at this with how you work with individuals, families, groups, organizations, and communities. And I would dare say, even when you evaluate, you sometimes have to go back to the beginning, to maybe not to the engagement aspect, but certainly the assessment. So it's important to have ongoing evaluation. Starting telesupervision, it's important to be resourceful. You as the supervisor, you're not supposed to know everything, but you better know where to find them if you don't. And you need to model that resourcefulness for your supervisees. This is certainly my ethic. You need to be patient. Sometimes people come to clinical supervision, maybe not having near the, maybe you feel like they're not quite where they might be getting out of school, right? But you need to be patient with people. It's amazing to see the kind of growth I've seen over years with people, but you need to be patient with their questions, patient with them not feeling like they know much, or even being imposters. I've seen lots of people come into supervision feeling like, why are they here? Can they actually do this work? And it's important that you are there for them to discuss those kind of questions. You really need to be imaginative as a supervisor. You need to be able to bring things up in a different way if they're not able to understand something in one way that you've explained it. And by golly, you really need to be tenacious. You've got to be tenacious with folks and try to make sure that they are, that they're understanding what you're trying to teach, but you're also trying to be consistent for them. And I love this picture of the mama elephant with the baby elephant. This is for both the supervisor and supervisee. And what I get from this picture is really that we're trying to bring people along. We're trying to lead them a bit, but we're trying to gently bring them along to be able to work with us. And these qualities, resourcefulness, patient, imaginativeness, tenaciousness, it's both for the supervisor and supervisee. And quite often I will share these items with them, that this is what I expect, especially in early supervisee sessions. And sometimes I have to bring it up as time goes by. Life happens to people in supervision, and sometimes you need to come back to these again and again. You need to have that well-developed contract, like I said earlier. You should have an outline of goals that they want and have. This is something I've even called it a wish list. If you got out of supervision with me, what would you like to be, last day we had supervision, what would you like to have on your plate? That helps to outline those goals. It addressed the structure of supervision, that you expect them to come with a question or some questions, cases to present, these kinds of things. It discusses the responsibilities of both parties, like I said earlier, and it clearly outlines the liabilities and responsibilities. Again, we work quite a bit with different agencies across the state, meaning our supervisees are in different agencies, and we make it clear that their agency has the last word in any kind of case outcome. You need to be accountable to professional and ethical standards, you as a supervisor and they as supervisees. Sometimes you need to share that with them. I've had, my goodness, I've had all sorts of interesting things come up. You need to always keep the supervisee's interest at the center of supervision, even though it's really important that you do have a lot to impart and you want to impart that. It's important to try to pull out of that supervisee what they might do, and certainly share, and then you can share with things that you do best. You provide an opportunity to reflection, and I think that this is really modeled within how you do your supervision, how you reflect upon your own practice. Certainly, my practice as a supervisor is much different now. Clinical supervisor is much different now than it was when I first got into social work some 28 years ago. So it's quite different. And then you need to critically evaluate that supervisee's work. Remember that the supervisee's responsibilities, this is for their own learning, okay? That they need to be prepared for supervision. They need to present their work openly and honestly. This is something that as a supervisor, you need to build trust within that relationship so they feel able to share that with you. And that they should have a growing self-awareness within the context of the supervision. That they have a self-awareness regarding cultural, religious, racial, age, gender, and sexual orientation differences between themselves and those that they're working. When I first started working with children, I did not have children. And it was really interesting for me how I really felt about it. That was a great topic for my personal supervision. And now that I'm so old that I could be a grandparent, it actually gives me a very different self-awareness. And so it's important that we encourage that with our supervisees. There also can be costs to supervision. This is your financial considerations. Costs are usually the same in person or through telesupervision. However, it really eliminates that commuting time, which increases your productivity for both parties. Jen has actually calculated this to the nth degree, and I don't have it up on this slide, but I might have it in the slide coming up. There's a huge savings for people to be able to have telesupervision. Just like there is a huge savings for people to come here today and be able to participate in this symposium from your comfort of your own home or office. I'm going to be transferring this to Lisa.
Okay, so we're going to talk about telesupervision strengths and challenges. So what have we encountered in terms of the great things about clinical telesupervision, and where are some of the areas of growth? And Molly, you're going to have to forward the slides for me. So strengths of telesupervision. So the best thing I think about telesupervision is that it makes supervision more accessible. And especially in a state like New Mexico, we, are a very rural state. And so if you come from a very rural or frontier community, then supervision is hard to come by. And unfortunately, in New Mexico, we have, a behavioral health workforce shortage. And so supervisees come here or they live here in a frontier community and they have an LMSW. I'm talking from a social work standpoint because that's what I am. And the same is true across all disciplines. People who have a lower level of licensure maybe working for years before they have access to someone who can provide them with supervision. So what telesupervision does is it brings that access right into their home, into their office. And as Molly was talking about earlier, it increases the flexibility, and it increases productivity because you're not commuting commuting an hour to get supervision somewhere else. So I think it's just wonderful in how it brings people together. Molly, okay. And so I do group telesupervision, and so does Jen. And we're going to talk about our program a little later in the slides. And it's really interesting doing group telesupervision because I come from a long therapy background clinically, and I think group therapy is a wonderful way to do therapy with clients because they just get so much from other people who are peers and other people in the group. The same is telesupervision is not therapy. I want to make that clear. But in group supervision, people get the opportunity to for personal growth because there's so many professionals in this group, and they get exposed to a wide variety because they may be from completely different communities. From all corners of New Mexico, for example. And so in group telesupervision, you're meeting people who you would never otherwise meet in person or on site. So there are some concerns that people have about telesupervision. And I think, now that we are, again, in this COVID-19 environment, I think some of those concerns are falling away because we're in a position right now where we have to provide telesupervision, telemeetings, teletherapy. But what we have heard, prior to COVID-19 is that telesupervision can make relationship building more difficult. That's been a concern in the past. And I'm not going to address the concerns on this slide. I'm just going to tell you what the concerns are. The other big concern in many communities is that the supervisor may not be familiar with the community because they're not in the community. And that's certainly a really valid concern. And that people have concerns about using technology. It's not all of us are digital natives, and it can be difficult and a little bit intimidating at times to learn technology. Although again, I think people have a lot more experience now than they did 8 months ago. And then, there's a question about how are you going to process cultural issues if you're not in the community where the supervisee lives. So a lot of the concerns revolve around this separation because you are obviously remote and you're not on the ground. And so those are concerns that have been fielded when talking about clinical telesupervision. And then I think the big one is this bottom bullet here, concerns about how a crisis is handled, right? I think Molly alluded to this earlier. The agency supervisor, the site supervisor, is the one who the buck stops at them. And so they are the one with the final say in terms of how a crisis is handled. And that is made very clear in our contract and also in the first few sessions with our supervisees. I always tell my supervisees we can always process the crisis and talk about it and talk through it, but in terms of decision making, your agency supervisor has the ultimate say. Okay, so what can we do about some of these concerns? And this has been, I started providing telesupervision when I started at CBH was about 2 years ago now. And at first, I had some similar concerns. How am I going to connect with these social workers from very different communities, from communities that I've been in? And I have to say that one supervisee in particular works in a tribal community. She does equine therapy, and it's basically on a property on a ranch. And it's just, that is a venue that I didn't have any familiarity with. And so one of the things that I did, and we're going to talk about this in a minute, is do a site visit. And so that can really help, doing a site visit can really help with bridging those gaps and developing trust. And I'm not saying, so, you know, nowadays it's hard to do a site visit, right? We may not be in a position to do that, but I think that when you can, I think one site visit goes a long way to bridge these gaps in communities and help people see this person is willing to come out here and really get a sense of my community and get a visual. Where does this person work? What clientele are there? You know, who does this person interface with? At least that's very helpful for me. So, you can move on. We can go forward. Yeah. Okay. So so this is for challenges for group telesupervision. What do we do? You know, what are some of the concerns about it, and how do we address these concerns? And you know, Jen and I do group telesupervision at CBH, and with Zoom or with whatever platform you're using, doing supervision and or therapy or anything on a screen can be difficult to get used to at first. So social cues might be more difficult to interpret, especially if you're in a group setting. You really have to be on it as a supervisor, making sure that you're paying attention to everybody's body language as much as you can. Sometimes it's hard because there's, you know, a couple seconds of delay, and that can be difficult. So what we've found is that it's really helpful to call on people. And it's also really helpful to have a very clear structure of how the group session is going to proceed. I like to start every group, much like I would in person, but I like to start every group with a check-in. And sometimes that check-in can be different based on, you know, how everybody's doing. One wonderful check-in that I've used is, let's talk about a rose, a thorn, and a bud, which is like an area of growth that you've experienced. And that can really help people see where they're at, you know, both emotionally and intellectually as you're doing group. Okay, so this is a great, Jen found this last year before we did this presentation or a version of this presentation for NASW. And if you haven't seen this excerpt, it's an NPR program. It's like a little NPR program about rural life and just life in rural America. This is like a 5-minute excerpt, and when I'm done talking, I can put the link in the chat to the actual interview. And what it talks about is that technology, a lot of us, oh, thanks, John. A lot of us take technology for granted, you know. About a quarter of Americans live without water, live without electricity near them, and so they, you know, have, in this interview it talks about people using lanterns for electricity and propane, and so we just need to be mindful that technology is not something that we should take for granted. And with some of our supervisees in low bandwidth and rural areas, we just need to be really patient. And as Molly talked about earlier, patient around technology issues is important. And luckily, with social workers, we can do phone supervision, and sometimes that is a great resource if you just can't connect. And it's, you know, I say that lightly because in some of these communities, phone isn't even possible. But anyway, I just encourage you to take a look at this. It's a really good interview. Okay, so how do you start telesupervision, and what do how do you make it sort of seamless for the supervisee? One of the things is to address teleconferencing etiquette, okay? And again, I think we're doing a lot better around this in the last 8 months than maybe we have a year ago. But one of the things that I tell my supervisees is really you shouldn't be doing anything on screen that you wouldn't do in public or in a classroom setting. And a lot of times, using online education as an example is really helpful because, I'll use the example of, would you, paint your toenails in class? And they say no, and so it's, they're not going to paint their toenails in supervision too, in telesupervision. So just making sure that they understand what those boundaries are. And I have to say, I've never had a problem with this, with the supervisee at all. I mean, we're working with adults and with professionals, so I think that we really need to give them the benefit of the doubt here. And not to make sure that we don't sound too condescending around this, but just, expecting the same kind of professionalism in person as we do, or online as we do in person. So being on time, and that's for the supervisee too. It's important to be on time as much as you can, and if you can't be on time, to communicate why. So the next two slides are talking about telesupervision and cultural humility. I just want to say a caveat that we could do a 3-hour training on this, and there is going to be more on this in future workshops in this symposium. But I just feel that it's very necessary to at least touch on. We need to be aware of our own cultural stance in the world and how it intersects with our supervisee. And if our supervisee is very different culturally than we are, which is certainly going to be the case because culture is made up of so many different things. It's not just our race or ethnicity. It's ability, it's gender, sexuality, education level. It just goes on and on. So we really need to be aware of all of those differences and be prepared for it to come up in supervision, and to be as transparent as possible and to really be comfortable with saying, I don't know about this culture, or I don't know about this client's cultural considerations, and maybe we need to do a deeper dive into what the cultural considerations are and being really careful about how we address this. Because as social workers, again, we talk about person and environment. A person is subject to their culture, and we have to do as much as we can to promote empathy and be where our clients are. And I try to do teaching of that as much as I can. Okay. So again, it's important to understand how people see themselves in their agency, community, and world. Okay. Brene Brown has a great little video around empathy, and it's very basic but very clear. And I think it's a wonderful thing to show people, and I'm sure a lot of you have even seen it. Talking about what is true empathy and really understanding how to empathize with your supervisee as they are in their agency, in their community, and in their world. How do they see all of those things? And oh, good. Jen is just on it. She has all the links available. And so it's just, as I'm sure you all are aware, we need to really try to understand who our supervisees are. Okay. So I think, Molly, this is you.
I'm sorry, I thought we had decided it was yours, but I'm very
Okay,
happy.
I'll go for it. That's right.
No,
That's
I'm very happy to, too. We work together a lot, so I'm happy to do so. And you can jump in, okay, whenever you think you need to. So, telesupervision and high quality practice, okay? We are part of a group here in New Mexico, I'm sorry, I'm forgetting the name, but it's the Clinical Supervision Work Group, I believe. And we put together in 2018, the Clinical Supervision Implementation Guide, and we wrote this 2018. And this was an interdisciplinary effort. We had psychologists, marriage and family therapists, LPCCs, social workers, and really did put a lot of time and effort on trying to pull together basic resources on clinical supervision and put this in this document. You can access this document, this URL, and this is on the New Mexico Behavioral Health Provider Association website. And it really is more, I'm just reading off the title here, but it's a practical implementation guide for community-based behavioral health specialty organizations. And we have a great deal of tools and that are practical and resources for you as well. High quality supervision really does lead to high quality practice. This is why we think it's so critically important to talk about. Clinical supervision provides people a foundation for strong clinical practice, expectations for client care and professionalism, and quality improvement for direct practice and administration. It really, clinical supervision at the levels of engagement, assessing and understanding the situations, and planning positive life-changing interventions, and getting and using results. Lisa? You're muted.
Oh, okay, there we go. So, high quality, I know we are sort of really getting close to time. So I'm gonna go kind of quickly so that at least we can get into our breakout rooms. So there are theories of supervision that we want to at least be aware of, and that clinical supervision guide that Molly just showed will tell you all of these theories and what they are. Reflective supervision is really reflecting the supervisee's experience. I love developmental theory because it sees supervisees across a developmental continuum from novice to expert. And it's really fun to watch people grow because in social work, we have these people for 2 years. And so it's a really great theory. And, the clinical supervision guide touches on these theories, but if you want to do more research, there's a lot of information out there. Okay, and then, so what we want to do here is the purpose of clinical practice is to help a person or family to achieve an adequate level of all of these things Okay, well-being, daily functioning, basic supports, and daily living, and fulfillment of key life roles. This is what we're trying to help people do. And so we want to make sure that we're talking about this in supervision.
And these are actually expectations, again, of high quality practice, that we have minimum practice core practice functions. And this comes from integrated quality service review. The basic functions of quality practice, and this is listed in our particular, in that guidebook that we were just talking about, is engaging service partners, knowing how to do that. How do you really engage somebody into practice so that they'll come in and see you and work on some issues with you? Your ability to assess and understand the situation, skills that are important, that you really know what's going on within the context of the client and your life. Plan positive life change interventions, things that can actually help this person and get them motivated and excited about, oops, sorry, let me go back one, about those interventions. You help them, you implement their services, and how do you do that? And then how do you get results from client interaction, and how do you use those results to help the client? Clinical supervision should provide support, consultation, and oversight of the client treatment, and that should include a needs assessment. You need to find out what the client is needing from you, and you as a clinician needs to do a good assessment, a diagnosis, and a differential diagnosis. It's important that you utilize your DSM-5. I will say that 100 times. It's important that you use your DSM-5. There's lots of great information in it, and we all should be able to come up with a clear diagnosis and a differential diagnosis. There is important to have some clinical reasoning in case formulation. Clinical reasoning is that critical thinking that you're using and that you put into practice. And how do you formulate cases? I don't think a lot of time happens in this area of case formulation. It was something that was ground into me in my education and in my clinical work early on. We could do a whole thing on case formulation. I would love to do that. Documentation. It's important for quality clinical supervision that you teach your supervisors how to document. Excuse me, I apologize. Refined treatment plan and implementation. How do they do that? And how do they communicate that and implement that with their client? How do you refine those treatment goals and outcomes? Treatment goals can be, they can be done, but they're not set in stone. You can set them, but you may need to go back to refine them to better meet the needs of the client. And then how do you go about selecting interventions and supports? Quite often I like to work in collaboration with my clients to do that. There are certain things that I would like to put into place, but I really try to work as collaboratively as possible. How do you coordinate that care? Coordinate care between in the community for this client and possibly with their medical provider, or psychiatrist, or nurse practitioner, or psychologist, prescriber. How do you coordinate that care? And then how do you track and adjust interventions? There's lots more on this in our clinical practice supervision guideline. And I'm not going to go over this in extreme detail, but when you're working with individually with the practitioner, this is individual practitioners level supervision. You need to always continuously review and adjust according to the individual status, success, and challenges. Continuity is critical through all the documentation. Ensure plans, interventions, goals, and supports are appropriate to the diagnosis and aligned with the supervisee's theoretical orientations. Use parallel process where the supervisor's development is being addressed alongside the emerging clinical issues. This happens all the time. It happens within supervision, where you're doing supervision for somebody and there's a parallel process between the supervisor and yourself. The supervisee, excuse me, and yourself. There also, you need to address the supervisee's steps to ensure that their active involvement at all levels and that the individual voice and choice is clearly represented and documented. We need to ensure that discharge planning starts the very first session. You need to be sure that you're talking about length of treatment and when you plan to discharge the very first time you meet with people. And also, critically important to ensure that an appropriate safety and crisis management plan is in place at the onset of that delivery service and address ethics and ethical dilemmas. For group level supervision, it just reinforces that multidisciplinary teaming. Although I'm not doing group supervision now, I did it for a number of years when I first started this program 6 years ago. It serves as that great teaching and training venue that Lisa was talking about. It helps to, the clinical supervisor's experiences in group supervision can also inform, so I'm so sorry, and strengthen the work of the entire team. I think it also models how to do group practice. I think group supervision is awesome because it shows your supervisees how it can be done. It helps them understand what a structure is like in a group and how do you implement that and how do you follow it. It models facilitation of a group. How do you facilitate groups on a whole? It also models how to utilize each other for ongoing consultation. Early on in my groups, I really encourage my group members to talk to each other so that they can, and get their contact information so that they can utilize each other if they need consultation in the future. It assists supervisees in examining their practice and then, of course, in the practice of others. And I really see group supervision as being a synergistic effect. It's greater than the whole is greater than the individual. And I love that. Lisa?
Okay, so going on to talk about just how do you develop this relationship, much like therapy, much like case management, rapport and engagement is key. Okay, so that's what you're going to spend a lot of, especially the beginning time of supervision, doing with people, is building trust and helping, you know, supervisees build trust with clients, because if they feel held in supervision, they are going to be able to develop more of a trusting relationship and build rapport with their clients. And so again, I feel like I'm a little bit of a broken record talking about COVID-19, but we really want to make sure that we're bringing current events into supervision and really making sure that we're, you know, talking about supervision in the here and now. How is your supervisee doing in the here and now? How are they, you know, how is their burnout level, their compassion fatigue? This can be important to talk about. And if you find yourself talking about burnout and compassion fatigue a lot in your supervision with supervisees, then, you know, having a career discussion with them about where the agency that they're at is a good fit for them. I've had many discussions like that with people, and really, you know, being open to empathizing with where they're at, and developing rapport. The thing that I love about doing this is that you really do get to develop a strong relationship over a 2-year period. And it's very enriching. I love this, establish a website manner, right? So if you're online with people, you know, and what I've found in doing clinical supervision on the computer is that the screen, if you have a good relationship with your supervisee, the screen tends to fall away, and it becomes more like an in-person session, and the screen becomes less and less distracting. One thing and I really think that structure on Zoom, on, you know, telesupervision is really important. And these things about clear beginnings and endings, you really want to start on time and end on time, minimize distractions. If you're a multitasker and you're used to doing multitasking on Zoom or online, really try not to do it during supervision. They know you're not paying attention because it's very obvious. They just can't tell what you're doing. So if you're looking something up or trying to write something down, just let them know, I'm writing this down because I want to make sure that I get all of, the details of the case, for example. And, eye contact can be a challenge. I feel like eye contact is a challenge. I still don't feel like I have that mastered. I feel like my eyes are kind of all over the place. Um, and so I ask for feedback. And, sometimes, and most of the time they tell me, no, you're fine, it's great, but we have different perceptions of that. So it's just important to put it all on the table and really be as transparent as possible. Okay, so here's a little more about the developmental theory of supervision, and I don't want to go too far into it because there are other resources for this. But as I said, the developmental theory is novice to expert, and so as a novice, you're going to see limited skills. At a middle stage, you're going to see increased confidence, and kind of like an adolescent, they might start to push back a little bit in this stage. And then as an expert, you're acting more as a consultant than you are necessarily being super directive. And so where do you start with teaching supervision? I mean, teaching clinical practice. When somebody is at the very beginning of their practice, you really want to work on developing assessment skills. Their ability to do a good biopsychosocial and provide a good diagnosis, and really, I have my DSM right on my desk and I pull it out all the time, and go through it with supervisees to help them work on diagnosis. Because what I've found is that diagnosis, unfortunately, I think the schools try really hard to teach diagnosis, but it doesn't always seem to stick because not everybody does work that requires diagnosis of patients. And the way that you learn diagnosis is by diagnosing. So talking about that in supervision is really important. And skill development, right? Encourage well-written and timely documentation. And it's important to help them develop this skill, because we don't have time to write lengthy progress notes, for example. We want to learn to write concise, quick, but very information-packed progress notes. And you can use screen sharing. That's the wonderful thing about Zoom, that you can, or any platform really. I'm not sure about the others, but I know Zoom does great screen sharing, and you can show what you're doing and how to write a good note with de-identified examples. And asking them to journal and write down what they're getting out of supervision and what would be helpful for them to go over in supervision is important too. Okay. And so high quality supervision provides all of these things: assessment, diagnosis, you're making case formulations. I think that's a great place to practice case formulations. And, exploration of parallel process. So I think what I'm going to do is, Molly, why don't we move forward, because I want to really try to get into the breakout rooms.
Yeah, I think that's a great idea. I'm just moving quickly forward here. This is just our ACTION Mexico Telesupervision program. You can look at the slides. We've been doing this for a number of years. And there was no cost to supervising. This is where that slide I talked to you about with Jen, 2,500 hours of supervision. It would have they had to drive 2,400 miles to get to us. And we wanted really to save time here for a breakout. And we are going, Jen has graciously put you guys into breakout rooms. You don't even know that. She has. And so these are the items I would like you to think about when you're in the breakout rooms. And Jen, will these questions be posted in the chat? Or is it better to, go ahead.
I can put them into the chat really quickly.
I could do that as well.
I can
but we're really wanting you to talk in your groups about what your experience are with telesupervision. Do you have concerns about starting telesupervision, and might that be? What would you implement in a telesupervision program in your community? And what would the barriers be in your community and region?
Okay, so as everybody is jumping back in, you know, our slides, we have a lot of information. And so we bumped up against the breakout rooms and unfortunately don't have as much time to talk about this as we would like. So, and there were actually a lot of questions in our breakout room. So if you could just put, if people could just put in the chat, you know, what were some of your experiences in discussion? And, you know, what have some of your experiences with supervision been? Clinical telehealth supervision, and, you know, and or what did you learn? You don't have to answer all those, just you can make some comments in the chat so I can facilitate like a 2-minute discussion.
Hope that you were able to talk with each other and get some information and share today. I'm seeing some heads nod. I saw Karen Curtin's head nod. Good.
Yeah, it's so wonderful to see so many people in this workshop, and I just wish we had more time. Okay, so we are open to learning as both of us have not done supervision. Discuss different experiences and challenges. We realize that we have varied preferences. Yes, I'll bet. Thank you, Sandra and Michelle. Great to hear others. Multitask with supervisees. Whoa, now they're coming. Wonderful presentation. Great. There was some discussion of perhaps a need across the state for networking. Yes. Supervisors in this area. Yes, excellent. Marie, thank you for saying that. And I think that that's a great point of discussion. And talking about crisis and supervision and how to process that and work with that. Thanks, Jason. Yeah, so that's great. I'm glad, even though it was super fast, you had some time to discuss. And as Molly said earlier, please share your contact info, and hopefully, you know, especially in these rural frontier areas, you can connect. So yeah, that's great. This was wonderful. I'm going to turn it over to Jen to do some housekeeping stuff.
Before we turn it over to Jen, I just wanted to say we have our emails at the end of this. And so if you need any resources, you want to connect, please do so. Thank you.